Hello, and welcome to another edition of the Kayal Ortho Podcast. Today is June 22nd, 2023, and I'm very privileged to have our very own Dr. Victor Ortiz with us today. Dr. Victor Ortiz is a board-certified, fellowship-trained orthopedic surgeon at the Kayal Orthopedic Center. Dr. Ortiz has completed 2 fellowships, one in the area of sports medicine and arthroscopy, and the second in the area of hip preservation. Today's focus is going to be all about how Dr. Ortiz introduced 2 cutting-edge technologies to the Kayal Orthopedic Center in the field of hip replacement surgery. The first is the introduction of the MAKO robotic-arm assisted total hip arthroplasty, and the second is the introduction of the minimally invasive direct anterior total hip replacement through the front in a very minimally invasive manner. So we're so honored, privileged, and pleased to have Dr. Victor Ortiz with us today. Welcome to the podcast, Dr. Ortiz.
Thank you so much, Dr. Kayal, for having me today, and look forward to discussing hip replacement and robotic surgery.
I'm so happy to have you. So before we get started, why don't you just tell the audience a little bit about yourself, Dr. Ortiz?
I grew up in Puerto Rico, born and raised. I came back to the States approximately 7 years ago with the whole family. We were probably never looking to do the move, but luckily we came to New York. My wife is also a healthcare provider. So while she was doing her training, I was practicing in northern New Jersey. And so far, we love everything. It's been a very happy adaptation to the whole family, and we're excited about it.
And we're very excited to have you. Tell us a little bit about your professional education as well.
So I did my medical school in the School of Medicine in Bayamon in Puerto Rico. After I finished my medical school, I went on to orthopedic surgery, and I did my residency in orthopedic surgery in the University of Puerto Rico Medical Science Campus. After I was done with residency, my next goal was to do a subspecialty in sports medicine. And I went to Chicago. I did the University of Illinois at Chicago, where I trained in sports medicine, mainly arthroscopic procedures of the shoulder and knee. During my fellowship, I always had an interest in doing hip arthroscopy, so I met one of my mentors at that time, and he invited me to join his fellowship called the American Hip Institute, in hip preservation surgery. And during that year, I was really able to focus on 2 main things that I really want, was the hip arthroscopic procedure, but also the direct anterior approach. So I did a second year in Chicago doing these 2 outstanding procedures that I think have really changed my practice. Also, it is interesting because during training, during residency, I always said that I would never do a hip replacement. And now it's part of my practice. It's what really has allowed me to build up a practice and reputation in the area. But the long story short, during my fellowship in sports medicine, I said I really want to improve my skills in hip arthroscopy. So when I decided to do the second fellowship, the downside for me at the time was, well, you have to learn anterior approach and robotic surgery. So I said, okay, let's do it. Long story short, I went in there. I love the approach. I love the outcomes of the patients. And now it is probably the majority of my practice. And I'm passionate about it. I love the direct anterior approach, the robotic surgery. I do everything that way. If I don't have the robot, I don't do the surgery. and it's been really a game changer for my career.
Wow. Dr. Ortiz and I have been great friends and colleagues for many years now, and this is the first time I'm actually hearing that story. So that's something I didn't know about you, Dr. Ortiz. It's very interesting. Well, thank God you did receive that training from one of the finest institutions, not only in the United States of America, but in the world. That fellowship is very much considered a thought leader in this area of hip replacement and hip preservation technology, and we're just so privileged that you learned from a master surgeon and were able to bring that technology to northern New Jersey and the tri-state area and introduce it for our patients and our community to benefit from. You certainly have become and are now a master surgeon in the area of hip arthroscopy and hip replacement surgery. So we're very fortunate to have that technology, especially with us at the Kayal Orthopedic Center, because of Dr. Ortiz. Before we continue our discussion regarding what that technology is and why it's so beneficial to our patients, I think we need to start with the basics, the fundamentals. And let's just even talk about arthritis. What is arthritis? What types of arthritis exist, and why do they exist, and how do they present? What are the symptoms that are associated with arthritis? And which types of patients would ultimately benefit from your expertise?
So I think there are multiple types of arthritis that affect the hip. I always think that when I explain to the patients, the common denominator here is that the patients are losing cartilage in the joint. It's like the wear and tear, the bone on bone, and it can happen in different ways or modalities. The one that we know the most, the wear and tear of the hip or osteoarthritis, is the most common one, the one that a lot of the patients have. And they present with this bone on bone disease, stiffness, difficulty like pain along the groin, difficulty getting in and out of the car, really difficulty with prolonged walking and affecting really their daily life activities. It's hard to put your socks and shoes, and it's really hard to do the things that they enjoy, like playing golf, playing tennis. So simple things that the elderly population want to enjoy is being really affected. There are other type of arthritis, and for example, inflammatory arthritis that can see in patients with chronic autoimmune disease, like rheumatoid arthritis, like lupus, for example, where the immune system creates a response against the hip joint, causing the same wear and tear. There's another arthritis, like post-traumatic patients that have car accidents where they have acetabular fractures or fractures in the socket. They can have fractures in the femoral head that can lead to advanced or progressive wear of the joint, where they subsequently need a procedure. There's also infectious process or septic arthritis, where an infection creates inflammation of the hip joint, causing the same common denominator of wear and tear. And interesting with the septic arthritis, you can see the damage as soon as 8 hours after the infectious process. So we in orthopedic surgery are very aggressive in treating them because we know the sequela and what can happen in patients with possible infections. There's also osteonecrosis or avascular necrosis, where there's a blood supply insult to the hip joint, where the patient develops loss of blood supply or circulation to the femoral head. They develop necrotic bone and subsequently end up with having wear of the joint that might need surgical intervention.
Yeah. So we've mentioned the term arthritis, right? So to break that down for our viewing audience, arthro means joint and itis means inflammation. We've talked in the past that inflammation can be associated with redness, warmth, swelling, and pain. And then arthro represents the fact that the joint is involved. So arthritis is inflammation of the joint. So you can get redness, warmth, swelling, and pain in that joint. As Dr. Ortiz alluded to, that arthritis or inflammation and pain is associated with a destruction of the joint for a whole myriad of different reasons. The most common, he said, was the typical wear and tear, degenerative osteoarthritis. But there are other types, all of which can definitely benefit from treatment, ultimately, with Dr. Ortiz with a hip replacement. The worst of those that was described was the septic arthritis, because that's where you have an infection in a joint, and certainly that becomes very, very complicated because you'd never really want to put an implant in the presence of infection. But for the most part, all the others, osteoarthritis, inflammatory arthritis, avascular necrosis, those would benefit tremendously, ultimately, from a hip replacement. So we talked about some of the definition of arthritis and some of the classic presentation symptoms: groin pain, difficulty getting in and out of cars, difficulty putting on socks and shoes, restricted range of motion, and a limp. But there are changes going on inside the joint that are very characteristic of that arthritis. Dr. Ortiz mentioned essentially bone-on-bone wear and tear of the cartilage. There's other changes, right, Dr. Ortiz, going on with respect to possibly the labrum, the fibrocartilaginous labrum, and also the fluid inside the joint as well. But before you even answer that question, just for our viewing audience, what are the different types of joints? Like, what kind of joint is a hip joint as compared to, say, a knee joint?
So the hip joint is a ball and socket joint, similar to the shoulder, compared to the hinge joint of the knee. So every joint is made different and has special roles. I think when we have a ball and socket joint, there are multiple things. I think for me, the most important one is that the ball and socket with the extension of the labrum. So the labrum is an extension of the socket, creates a suction seal mechanism to first provide stability, but also allow the function or mechanics of the hip to function correctly. To be able to you have adequate mobility, that the properties of the synovial fluid of the cartilage are protected to decrease the inflammation. Because at the end of the day, inflammation is what causes pain and is what causes the damage. So our goal really with the treatment of any type of arthritis is really to bring that inflammation down to decrease the chances of having subsequent or more damage in the hip joint.
Right. Yeah, it's interesting you mentioned the labrum. And by the way, we will allude to the labrum in the future. Dr. Ortiz, as I mentioned, is a master hip arthroscopist as well as a hip replacement surgeon. In a subsequent podcast, we will be interviewing Dr. Ortiz on the subject of hip preservation, where he addresses labral tears. So stay tuned for that. But with respect to the hip arthritis, and the role of the labrum and the joint fluid, what we call the synovial fluid in the joint, I often give the patients the analogy of a gasket on a car engine, right? Because we have a car engine, we have the cylinders, we have the pistons going up and down, and the most important thing in there is the oil, the engine oil that's lubricating that mechanical construct, right? If there's a gasket leak and that fluid can leak out, the oil you can freeze up a piston in a cylinder, and it can jam and cause engine failure. The same analogy I give when I'm talking about labral tears and referring patients to you for that. When there's a labral tear and that fluid could seep out, and you lose those mechanical properties inside that ball and socket joint, that seal from that labrum. That helps to keep that fluid in there and provide those mechanical properties. But again, we're digressing a little bit because it's also very, very important in the area of hip preservation, where we're actually referring patients to Dr. Ortiz to fix and repair the labrum, so ultimately they hopefully do not end up needing a hip replacement. So that's another podcast. But for now, I think it's important to just understand the anatomy, the fact that the hip is a ball and socket joint. You have this big round ball sitting inside a big bony cup, and around that cup is a labrum, a fibrocartilage labrum that basically seals that joint, that construct, to allow that fluid, the synovial fluid inside the joint, to stay inside the joint, just like that car engine gasket we talked about, to provide those mechanical properties to that ball and socket joint so that the patients, like Dr. Ortiz said, less inflammation. So now you understand the function of that fibrocartilaginous ring of tissue, that seal. Are there other anatomical structures that come into play in a healthy, non-arthritic hip joint, Vic?
Absolutely. I think one of the most, besides the labrum, one of the most important structures is the articular cartilage. And we know the articular cartilage in every joint is a little bit more smooth than the labrum, is a collagen type 2. And it really gives some of the properties of the joint, like load bearing. And when we start losing that, that's when we, as you mentioned before, with the gasket, and that's when we develop problems, and that's when we develop inflammation and pain.
Right. So what you're essentially saying is that this articular cartilage is essentially different from the cartilage in the labrum, right? The labrum, there's something called collagen that we have in our body in different areas, but in orthopedics, it's relevant primarily in the area of bone and cartilage, okay? In bone, that's type 1 collagen. But in the meniscus and in the labrum and in the intervertebral disc of the spine, that's also type 1 collagen. But in the healthy joint, there's a different type of collagen in what we call the articular cartilage, the cartilage that is essentially stuck to the end of the bone. So if you have a hinged knee joint of the knee, that type 2 collagen makes up articular cartilage, the cushion on the end of the bone. And the same thing applies in the hip too, right? In the ball and socket joint, you have that type 2 collagen, hyaline articular cartilage on the end of the bone, different from the cartilage that's in the labrum, right?
Correct.
So you're saying that with arthritis, that can wear down.
Correct.
And become thin, very thin, to the point where sometimes bone can be exposed, right? And that normal smooth surface is now sort of eroded, and it's not smooth anymore. It's bumpy, like potholes in a road, right?
Yep.
And then what about the joint fluid, the synovial fluid inside a bone socket joint? We talked about the labrum that contains it, but what about the fluid itself?
So the synovial fluid provides lubrication to the joint, helps in the load distribution, has a good amount of proteins that when we have arthritis, for example, the hyaluronic acid gets diluted. So those properties are not the same.
Right.
And all of that it contributes to the whole spectrum
Right.
of hip pain.
Right. It's a whole downward spiral. You're wearing the articular cartilage, you're tearing the labrum, and now the synovial fluid is markedly diluted over time, right? And that's why the FDA has approved some what we call intra-articular injections of hyaluronic acid, but is only FDA approved for the knee, where we can inject these products such as Synvisc and Orthovisc and others into the joint to try to restore the normal concentration of hyaluronic acid into that joint. Unfortunately, it's not FDA approved yet for the hip, but maybe someday. Thank you so much, Dr. Ortiz, for that very elaborate and thorough explanation about arthritis. How does arthritis typically present? Besides the pains you're talking about, are there other symptoms that are commonly associated with arthritis?
I think the main common, besides pain, which absolutely is one of the first signs that patients feel, limitation in range of motion. So patients feel stiff, they feel that they are limping, that they need to use a cane to move around because they cannot really stand on that feet. And then there's difficulties in their activities of daily life.
Right.
The most common one is like, listen, I want to go to New York City. I want to walk for a couple blocks, and I have to stop every block because I don't feel comfortable.
Mm-hmm.
And that's usually the what brings into the office is because they are really trying to do things that they enjoy and they are not able to. Another thing, for example, if we go to sports, and we know a lot of our patients, they like to play golf, they like to play pickleball, which is the new thing out there, and they have limitations.
Mm-hmm.
And they say like, I cannot perform. I get pain during playing. At the end, I'm miserable for a couple of days. So those are usually the type of signs or symptoms that patients are feeling that bring them to our practice to look for care.
Right. And I noticed over the years that it's often the family members that finally get them to come in, right? They're sick of them seeing them limp like this and not participate in family events. And they really strongly encourage them to just get it taken care of so they can restore their quality of life. So thank God for those family members, because a lot of times patients just opt to live with things and or don't even know that options exist, that we can actually get them out of that pain and restore that quality of life. And that's one of the reasons for this podcast, to try to educate our community of patients that you don't have to live like this anymore. There's a lot of things that can be done to help you, which we'll get to in a minute. But besides the pain, loss of motion, stiffness, instability, sometimes their joints can buckle and give way. Besides that, do they sometimes have pain in other areas and not the hip, even though it might be coming from the hip?
Right. There are two main places when I look at that. I think the first one will be the knee. And we have had a good amount of patients that they just come to the office with knee pain. You look at the x-ray, everything looks perfect.
In the knee, the x-ray looks perfect.
Looks
right.
perfect. You do an examination, feels pretty good. And then you start feeling at the hip. If the hip feels stiff, and then you get x-rays, and out of the blue, like it's bone on bone.
Right.
And it's not uncommon to see that, that you have radiating pain. I think one of the reasons being is that there's a small nerve under the hip joint that can get irritated and cause pain going down the knee, but it's really coming from the hip joint. I think the other one that it's very common.
By the way, not to interrupt you, but on that note, I mean, sometimes it's hard to convince patients that the problem is the hip. Not that we get in arguments with our patients, but sometimes they don't believe us. They say, there's nothing wrong with my hip. My pain is in the knee. And that is often sometimes the only presentation. Because the patient's having pain in the knee, we evaluate the knee. We take the patient's word for it. We get an x-ray of the knee, but there's nothing wrong with the knee. And the only thing sometimes that is wrong is the hip. And, I've done many hip replacements over the years for a chief complaint of knee pain. It's interesting. Ultimately, the patients concede because they understand we're the experts in that regard. But it is hard for them to believe that the problem is stemming from the hip and not the knee. And where else?
And I think the other one, which would be one of the most commonly missed, is when something that I describe to the patients as a hip spine syndrome, where patients are constantly told the pain is from the back, we can do anything else. And a lot of the times, patients with hip pathology can present with posterior hip pain. It gets confused. It might take 2 or 3 office visits for them to, the problem is the hip.
When he says posterior hip pain, he's talking about in the butt.
Is that
In the buttocks, like where possibly sciatica may present.
And usually they'll go to the primary care doctor, they'll go to the chiropractor or physical therapist, and they're told, it's the back, keep working the back. And out of the blue, same as the knee, you start looking at the hip, you maybe sometimes do an injection, and they're, everything changed.
We see that all the time. We see it all the time. So, it's important that patients see an expert and get a physical examination by an expert orthopedic surgeon with a tremendous amount of experience, because we tend not to have tunnel vision when we listen to our patients. We know the potential etiologies of pain in certain areas. Oftentimes, patients don't understand that the hip to the orthopedic surgeon is not the outside of the hip. It's the groin. So the hip joint for the orthopedic surgeon is the groin. There can be pain, like Dr. Ortiz is describing, in the area of the buttocks. That's still the hip, but usually pain in the buttocks is coming from the back. Pain on the outside of the hip is coming typically from soft tissues around the hip joint, but not the hip joint itself. But pain in the hip and pain in the groin can very often be stemming from the hip joint itself. Now that we've described hip arthritis and we've described the symptoms that are often associated with hip arthritis, does everyone with hip arthritis get a hip replacement?
No, I think that the answer is no. I think that is a very common thing for patients to come to, or not want to come to the orthopedic surgeon, because, as the word says, he's a surgeon and they don't want to have surgery. But I think that the first line of treatment, and for almost every orthopedic problem, is a conservative approach. And we do that with our patients. We try 2 or 3 months of conservative treatment, which includes a gamma of treatment that includes diet and exercising, good weight in our patients, physical therapy, where there's 70 muscles going around the hip joint. So if we work around those muscles, the load to the hip joint can be less and the patients can have a significant amount of relief. We try anti-inflammatory medications, sometimes combined with pain medication. And sometimes that is being shown that cortisone injections as a short-term pain relief can provide significant relief. And one of the things how I incorporate these injections in my practice is that when the patient comes to the office, when they decide to come, they're in pain. They need something. And that's where that injection really plays an important role. Brings the inflammation down, allows our therapists to work with the patient in a better way. Sometimes these patients will go to physical therapy. They'll flex the hip and they're not able to finish a session. The cortisone injection allows them to do that, allows them to be comfortable, allow the therapist to really do a better work, and they come back after 6-12 weeks and they have significant improvement of symptoms.
Just to elaborate on what you were just discussing, Vic, there is a common misconception that just because patients are coming to an orthopedic surgeon, that's all we do. Like, you only come to us when you need surgery. Nothing could really be further from the truth, right?
Right.
If we see 100 patients, we'll probably end up just scheduling 5 of those patients, right? Most of those patients are being seen for physical therapy prescriptions. We just do a physical exam. They might need a cortisone injection. They might need an x-ray and told nothing's wrong. Most of what we do is primary care and non-operative orthopedics, right? So you don't have to be scared to see us, okay? Don't be scared to get assessed by an orthopedic surgeon, Because I've always, and I say this during every podcast for the most part, most of what we do is non-operative. We should be your first call when you have anything wrong with your musculoskeletal system, because you're being evaluated by an expert in the field of orthopedic surgery, where we can assess and do a physical examination. We can interpret X-rays and MRIs and CAT scans. We can write prescriptions for medications, anti-inflammatories, give trigger point injections to help alleviate some of your pain, order physical therapy, chiropractic, acupuncture, massage therapy. Again, most of what we do is non-operative, so you should really rely on us to help quarterback your care. And then ultimately, if you do need surgery, we can do that too, but most of what we do is non-operative. So I did want to drive that point home. Also, you mentioned that you offer cortisone injections, right? And that dovetails off the fact that osteoarthritis is associated with inflammation of the joint, and there's no better or more potent anti-inflammatory than what we call an intra-articular injection of a corticosteroid. You know, arthritis, inflammation of the joint. Inflammation is associated with redness, warmth, swelling, and pain. And when we give you a cortisone injection, it very often alleviates that. For instance, what's been your experience when a patient is coming in to the office in severe pain with a horrific limp, and you lie them down on the fluoroscopy table in our procedure room and give them a cortisone injection into the joint? What's been your experience immediately thereafter?
So, I think that we also put some lidocaine in there. Usually a lot of the times when you put the needle in, you get some fluid out. So that fluid immediately decreases the pressure of the joint. So they feel sometimes immediate relief. And then when the joint is numb, it's like when you go to the dentist, right? You numb the joint. They're like, wow, my hip feels great. And when they come for follow-up, the amount of relief that these patients get, how happy they are.
It's unbelievable. Yeah. I can't tell you how many patients have gotten off that table and just gave me a huge hug and thanked me. I don't think there's anything that's more rewarding than that injection. When patients are limping and suffering in pain and you give them that injection, they're just so thrilled. And after I experience that with them, I say, guess what? That's exactly how you're going to feel after Dr. Ortiz does your hip replacement. I always tell patients that of all the conditions we treat in the field of orthopedic surgery, I don't think there's any operation or any disease entity that does better post-operatively than hip replacement surgery. It is probably the most rewarding operation we do. That and probably carpal tunnel release as well. They're just incredibly, incredibly successful operations. So now that we've spent a lot of time talking about all of this, let's get to the focus of the podcast, and that is the fact that you brought to the patients of the tri-state area here this incredible technology, two incredible technologies simultaneously. And those are, just to reiterate, the MAKO robotic-arm assisted total hip arthroplasty combined with the minimally invasive direct anterior approach. There were some surgeons that were doing the direct anterior approach. There were some surgeons that did robotic surgery, but Dr. Ortiz really pioneered these two cutting-edge technologies simultaneously in our area and has done hundreds and hundreds, if not thousands, of these operations over the past few years, just a master surgeon. So let's talk about one at a time, okay? So let's first talk about the technology of the MAKO robotic arm assisted total hip replacement. Just what is that? First of all, even before we get there, what is a hip replacement? Can you compare and contrast for us the difference between the traditional posterior approach that everyone's familiar with, and compare and contrast that with this new technology that you are bringing to the table, that you've brought to the table, about 5 years ago now, in the area of hip replacement surgery that pertains to the minimally invasive direct anterior approach?
Yeah, so the conventional approach, which is the posterior approach, which, as you mentioned, has been a very successful procedure in orthopedic surgery, and is the most of the surgeons in the country performs that approach. But I think that we are always never satisfied. We're never satisfied in orthopedics. We always want to see how we can make a great procedure even better. And I think that's where the approach with the direct anterior approach, we have been able to achieve that. When we do the posterior approach, the main, to get into the hip joint, we have to cut through normal anatomy. So that a lot of the times translates to having either temporary or permanent limitations or restrictions where patients are not really able to flex the hip too much, to cross their legs. They have to sleep with a pillow between the legs. They might need a bath commode, or they spend sometimes the functional recovery is a little bit longer in the acute phase. When we do the anterior approach, the biggest benefit of the approach is a minimal invasive technique where instead of having to detach normal anatomy, we go between the muscles. So we go in the front of the hip, you separate the muscles, and right there you're in the hip joint. I always tell the patients, that the biggest difference when we look at the ball and socket, and we'll do it later with the model, the socket is always looking to the front of the patient. So when you go to a house, you want to knock the door to the front, not to the back. It's harder to get in. So when we do the anterior approach, we separate the muscles, open the joint, and we can see the socket in front of us. I think if you make a poll, a lot of the orthopedic surgeons would say, I will never do a hip replacement because I'm not comfortable doing the socket. And I can tell you with the anterior approach, the socket becomes the easy part of the procedure. And I think those are the biggest difference between approach. I think if we look at evidence-based medicine, it's been clear that during the first 3 months in that acute recovery that the patients remember forever, the pain is less and the functional outcomes, the functionality of the patients is much better. And I have had a lot of patients that I do their hips when they had the other side done through a posterior approach, and they always say it's a night and day experience. It's if I knew about this, I would only do it through the anterior approach, and I think it's really been a game changer for my practice. I think it's been a game changer for the patients. It is allowing patients to be more comfortable doing outpatient total joint replacement, which is the future of medicine and orthopedics. And I think that is the way to go.
Yeah, definitely. We've seen it in our practice. It's really revolutionized the way that we do hip replacements in our practice. And the outcomes, like you said, are night and day. Patients have been able to compare and contrast posterior approaches to anterior approaches, and it's much more rewarding early on, especially. Through that posterior approach, you can do that in a minimally invasive manner, but it does not change the fact, even if the incision is small, it does not change the fact that surgeons are taking down important tendons and structures, detaching them in order to gain exposure, and then reattaching them at the end to provide stability. So that is really a major concern. The sciatic nerve is right there as well. There's a concern possibly about causing some iatrogenic injury potentially to that sciatic nerve. There have been patients in the literature that have woken up with foot drops because of injury to that sciatic nerve through the posterior approach. Clearly, there's a higher dislocation rate because you're taking down those soft tissues, and that's a problem. And so now that can, for the most part, all be avoided through this minimally invasive direct anterior approach. This minimally invasive direct anterior approach is often done through an incision. How big would you say?
Like this?
Yeah, about this big. I mean, to do the operation routinely. This has allowed us to, for the most part, really pioneer outpatient hip replacement surgery in the area. These are routinely done as an outpatient. Patients are now walking the same day on this hip and home in the comfort of their home within often 4 hours after surgery. So much less pain, much less invasive. Essentially, you don't even restrict the patients after surgery at all, right? With the posterior approach, our training is that Some surgeons say for 6 weeks you can't cross your legs, you can't sit, bend your hip more than 90 degrees, you can't internally rotate your leg more than 20 degrees. For 6 weeks, some people say for life. With the direct anterior approach, there's no restrictions. After the posterior surgery, patients would always get either a knee immobilizer or that big blue foam pillow between their legs, and they're sitting like this or trying to, go to sleep like this, and with this big foam pillow between their legs for 6 weeks. You don't have that at all, right?
Not at all.
You don't use the pillow. You don't restrict them from sitting in a sofa, sitting on a soft sofa or a toilet seat. You don't make them use a elevated toilet seat, nothing like that, right?
Nothing like that.
So those are the beautiful advantages of this minimally invasive approach. But it doesn't stop there, right? You didn't just introduce this minimally invasive direct anterior approach. You combine that with this second technology. And what is that?
So we combined the direct anterior approach with the MAKO robotic guidance. And that's been amazing. I think that right now, as I mentioned initially, if I don't have the robot, I'm not doing the surgery. That's how confident I feel that the robot is a complement to what we're doing. And the biggest things that we get with the robot is two things. I think that we do a CT scan on the patient before the procedure that allows us to customize the implants. We can design the implants to every patient's need.
And let me make something clear. Dr. Ortiz mentioned he's not doing the operation if he doesn't have the robot, not because he can't do it without the robot, but because he relies on the accuracy and precision of the robot. You see, he's designed these hip replacements on a computer before surgery, and the robot ensures that he doesn't inadvertently deviate from that preoperative design. So for instance, if he inadvertently were to angle his arm or his hand one way or the other, the robot would shut off and not allow him to proceed, because the robot ensures the precision of installation of the hip replacement to be consistent with his preoperative design on the computer and on the proprietary software program.
So before we start the procedure, we have the computer, and we design the implants the way we want it, to have a right tension, the right sizing of the implants. So once we go into the procedure, we can reproduce that to the patient's anatomy. And this is, for example, an example of the socket. So if we look at this, this will be the cup. So after we prepare the area where we rim the whatever is left of cartilage, we have adequate bleeding bone, because these implants grow into the bone grows into the implant. That's part of what we call ingrowth, bony ingrowth, which is an important characteristic of these implants to incorporate into the hip replacement. So what that means is that the bone grows into the implant to avoid any movement or loosening of these devices. So when I'm looking at the cup and when I'm looking at the CT scan from a 3-dimension standpoint, we want to make sure that the cup is exactly flush. And you can see how there's no prominence. The cup is not too deep, that we don't remove too much bone, that it's not a cup that is too small. Those are things that are very important. Sometimes we look at cups that are too big, and when we have a cup that is too big, that creates problem in the soft tissues around. We don't want any soft tissue to be irritated because we have a prominent cup. Then when we have cups that are not in the right position, we make patients can be prone to dislocation, and as we mentioned initially, but also when the distribution of load in the hip is not even. My belief is that we're going to load over one area of the implant more, and that implant will wear faster. So robotic has allowed us to put this implant where the patient needs, and we incorporate the balance of the spine. We incorporate the rotation of different bones to make sure that the patient doesn't have impingement, that doesn't dislocate, to give the patient a hip that resembles the native hip. And one of the things that I like to tell the patients is my goal with this procedure, with the direct anterior approach, with the robotic surgery, is that 3 to 6 months later, you forget that you have a replacement, that you think this is my normal hip. So the MAKO robot has really allowed us to work with the socket to make this procedure that doesn't have, the patients resemble itself. So, and then we go ahead and we do the stem.
So essentially what you're saying, you're installing that cup perfectly each and every time. You're trying to restore the normal anatomy of the patient. So if the cup is too big, it can result in some impingement of some soft tissues and some pain. If it's improperly positioned in a certain plane, it can result in instability as well. And so that's where the benefit of the robot comes in, where you design the precise placement on the computer, and then the robot ensures that you put it in exactly that way. So it's perfectly sized, positioned, and aligned each and every time.
Correct. So I think that's the first important intraoperative role of the robot.
As it pertains to the cup, as you mentioned, many orthopedic surgeons in this country will not even attempt hip replacement for fear of the acetabulum, right? I want to make sure we emphasize that point, because with this minimally invasive direct anterior approach, you're staring right at that acetabulum, so you can see it so perfectly. And then now with the robot will put in that cup exactly in the right position and angulation that you designed on the computer. So it essentially eliminates that fear of taking on the acetabulum, right? It's ensuring that it's perfect each and every time, and that has traditionally been the most challenging part of this operation that has typically dissuaded so many orthopedic surgeons from even doing hip replacements. And let me just drive home one other point, and that is that Dr. Ortiz is doing the surgery. It's not the robot doing the surgery. The robot just ensures that he does the surgery exactly the way he designed the surgery. And if he doesn't, for whatever reason, it just shuts off. It stops. And so one of the other advantages of using this robot as it pertains to the acetabulum is that it becomes a much more efficient surgery, right? You're doing the surgery more rapidly, and that's important to get patients off the table, right? Traditionally, we used to prepare the acetabulum in a sequential manner. If we were reaming to, say, a size 52 cup, we would maybe start at a 48 and then go to a 50 and then go to a 51 and then, gradually. This is a one-time ream for the most part, right? The robot knows exactly the angle, the depth, and it's a one-time shot, and it makes it perfect every time. So the robot comes in, Dr. Ortiz is guiding the robot. He sets the angle for that robot to ream and the size. It's a one-stop shop, and then boom, you put the cup in, you're done. And you're moving on now to the stem, right?
Correct.
So let's talk about the stem.
So then we will do the stem in a traditional manual way. So we have this is a sample of the stem. This is a titanium stem with a ceramic head. So what we do is that we first prepare the canal to the size of the patient that was already planned with the CT scan. And then we impact the implant. And same way as there's bony ingrowth in the acetabulum or the socket, there's bony ingrowth in the femur. The bone will grow into the implant and will become part of it. So once we have the right stem that we need, we go ahead and we do something we call trialing. And when we're trialing, we are making sure that we have a balanced hip. And that's where the second function of the robot comes into play. As I mentioned, we want to recreate this hip to be as the native hip, the hip that you had before that was functional. So,
and we talk about offset and leg length, right?
Right.
Yeah.
So that's where we put the joint together. And when we have the joint together, we can look at the robot and we can make sure 4 important things. And then it's going to be that the leg is not too long or too short, and that the tension in the gluteus or the abductors or the muscles in the side is adequate, that they're not too tight, that they're not too loose. So those are the things that really allows the patients to feel better. When you have the right tension and the right length, and it's a hip that is stable, we test the hip in different range of motion modalities, and the hip stays in the socket. That's when it's not too tight, when it's not too short. Those are the most common complaints of patients when they have trouble. My leg is too long. I feel so tight. And those are the things that the MAKO has really allowed us to perfectionate. Just the balancing of the soft tissues around the hip that are very important, and not only in the acute process, in the acute rehab of patients, but along the road.
Maybe even more important, right? It's we say with knee replacements, it's a soft tissue operation, and same thing with hip replacements. It's so important. The soft tissues have to feel good, right? It's one thing to resurface or replace a joint, but it's the soft tissues that have to feel good and have to provide stability and proper stability, right? If the soft tissue envelope is too lax, you might have an unstable hip.
Correct.
If it's too tight, you might have a leg length inequality or a painful hip because the soft tissues are just too stretched and too tight or limited motion. So both hip replacement, knee replacement, and you can probably extrapolate to shoulders and ankles, they're soft tissue operations. And that's where this incredible software technology allows us to tension the soft tissue envelope, with me for knees and with you for hips, to make it perfect. So not only are we putting in implants perfectly aligned, sized, positioned, but now the soft tissues are also happy. I'm sure you can elaborate on patients that you've seen over the years where the doctor might have done a beautiful job on x-ray, right? The x-ray looks perfect. We're looking at an x-ray, doctor's telling the patient, I don't see anything wrong. It's perfect. Just take some more Advil, do physical therapy. But really, the soft tissues are not properly tensioned in one capacity or another. Same thing with knees. Like the x-ray could be perfect, but the knee might not be balanced. And the knee might be tight or stiff or unstable. The soft tissues are very, very, very important. And unless you're a high-volume surgeon, you may not know how to handle the soft tissues as well as the high-volume surgeons, right? The literature is clear on that. The American Academy of Orthopedic Surgeons makes it clear that high-volume surgeons have the best outcomes. So you really want to go to a surgeon that's highly skilled, trained, and experienced in his or her area of expertise because, it's just like any other thing, right? You want a good plumber, you want a good electrician, you want a good, you name it profession. High-volume surgeons really have the best outcomes. We've seen it all, we've handled it all, and I think that's just important for our viewing audience to know and appreciate. And there's never anything wrong with getting a second opinion because it's very important that you know what's out there and to get the latest and greatest technologies. And that's really what we pride ourselves on at our practice, right? We're always trying to offer our patients the latest and greatest technologies in the area. And I think that's important to emphasize.
While I was preparing for today, I was reading about a study from Cleveland Clinic, and they were saying that by 2030, they were projecting that 60% of the patients will be having robotic assisted hip replacements. I think that's something that we have brought to the practice where almost I do 100% of them.
So Dr. Ortiz, this has been a fantastic conversation with you. I really appreciate your time.
We went over a lot of things today, and I'm very grateful. Thank you so much, Dr. Kayal, for having me today.